Yeah, it just depends what's
All right. Why don't I go ahead and get started?
Let's start.
So I'm not sure if either of both of you were here the last time I presented a few months ago, but this was my residency seminar presentation, just kind of investigating some new uses of ketamine. So I have nothing to disclose. Zach. So our objectives today, we're going to outline the history of ketamine use, describe the pharmacology of ketamine, and then we'll look at a few newer uses, specifically PTSD and refractory status epilepticus. So here's a timeline of sort of where ketamine has come from and then the direction that we've moved to closer to today with some newer uses. It all began in 1926 with the discovery of phencyclidine, more commonly known as PCP. This compound was shown to have variable effects in animal studies. It produced an excited drunken state in rodents, an immobilized state in pigeons, delirium in canines, but it was found to be a remarkable anesthetic in monkeys. So they tested it in humans and found that it did provide effective anesthesia, but a large portion of these patients experienced a very prolonged post-surgery emergence delirium. So they began trying to synthesize similar compounds that might be shorter acting, hoping to minimize this delirium. In 1962, they synthesized a compound first known as CI-581, later named ketamine. And it was found that this compound did produce very good anesthesia and was short-acting in animals. So in 1964, they tried it for the first time in humans. They started with a very low dose that produced minimal to no effects, and gradually increased the dose up to general anesthetic doses. And they did find that it produced minimal delirium compared to PCP. So in 1970, ketamine was FDA approved. As we all know, ketamine has been abused. Based on some of its psychedelic side effects, there is potential for drug abuse and dependence. It wasn't until much later in 1982 that they discovered the mechanism of action of ketamine. It's a non-competitive NMDA receptor antagonist, so it blocks glutamate transmission. And if we think back to biochemistry, glutamate is an excitatory neurotransmitter, so it's going to increase synaptic firing in the brain. It's also been shown to have agonistic properties at our mu, delta, and kappa opioid receptors, so this may explain why it has some analgesic properties. And it has no affinity for our GABA A receptor. At low doses, it's been shown to produce analgesia, and at higher doses, it produces this dissociative anesthetic effect, which patients describe as this out-of-body experience. So our first learning question today, which of the following is a property of ketamine that led to its development and preferential therapeutic use over phencyclidine? I think I heard someone say A, shorter duration, correct, because they wanted to minimize that emergence delirium. So as far as our indications for ketamine use, it's FDA approved for general anesthesia and for procedural sedation, but according to Micromedics, the off-label uses include acute pain, rapid sequence intubation, and bronchospasm, although as we'll see today, more recently there have been a number of other off-label uses. In terms of adverse events, the most important ones for us to remember are the psychiatric effects, including emergence reactions and hallucinations, and the cardiovascular effects. The psychiatric effects are important because it's a relative contraindication, actually, to use ketamine in patients with a history of schizophrenia, just out of concern that it might exacerbate their disorder. And that sort of begs the question, well, what about patients with other behavioral and psychiatric disorders? UVA here, we treat a lot of patients that have behavioral conditions. Is this drug safe to use in these patients? And then our cardiovascular effects are unique because unlike a lot of drugs used for analgesia and sedation, it actually increases blood pressure and pulse instead of causing hypotension and bradycardia. So now moving on, looking forward, we know where ketamine has come from, but we'll start looking at a few of the newer uses of ketamine that have been studied off-label. So I've listed here several different therapeutic uses that have been reported in the literature. And first, we're going to focus on, second learning question. Which of the following is an FDA-labeled indication for ketamine? Yes. Procedural sedation is the only FDA-labeled indication, although it has been studied in each of these. So first we're going to focus on post-traumatic stress disorder. So just a background of what is PTSD. Well, it's a cluster of symptoms following exposure to a traumatic event in which the event is re-experienced either through recurrent memories or nightmares, hallucinations. The patient tries to avoid stimuli associated with the event, so this could manifest as amnesia or detachment. And the patient often has increased arousal whenever they experience certain triggers related to that event. They may be irritable or restless or have insomnia. It's estimated that there's a lifetime prevalence of about 8 to 12%. Patients are at higher risk if they have experienced a traumatic event in their life, and it's estimated that 50 to 60% of patients report experiencing a traumatic event at some point in their life. The risk of PTSD is increased in patients with a history or a family history of psychiatric disorders. And it's really important for us to understand and manage this disorder because these patients are 6 times more likely to attempt suicide. It's believed that there are some stress-induced neurobiological changes that may contribute to the symptoms of this disorder. And some of these include a reduced volume of the hippocampus, cortical inhibition of limbic activity, alterations in cortisol production and response, and exaggerated sympathetic nervous system response when encountering these traumatic cues. We do have several different guidelines to help us steer our therapy, but many of these guidelines are conflicting. The VA, DoD, the APA, and the ISTSS all recommend medications and behavioral psychotherapies as first-line therapies for PTSD, but the NICE and WHO both recommend behavioral therapies over medications. They do all share in common a few similar themes. They all recommend against the regular use of anti-epileptics, antipsychotics, and benzodiazepines for treatment. And they all do recommend some sort of trauma-focused cognitive behavioral therapy in their guidelines. There was a meta-analysis published a few years ago that looked at 55 studies trying to determine whether medications or behavioral therapies were more effective. And in general, they found that these trauma-focused psychotherapies are indeed superior to medications. They hypothesized that perhaps the medications just act by blunting the symptoms, but don't really treat the underlying disorder. They did find a few medications that did demonstrate benefits compared to placebos. However, each of these has some caveats. Sertraline, there was actually a second trial that Pfizer chose not to publish, which had negative results. So perhaps if this had also been published and included in the meta-analysis, they wouldn't have found this positive effect with sertraline. Venlafaxine appeared to have benefit, but any benefit seems to diminish after 12 weeks. And mifazidone, although perhaps beneficial, carries a high risk of liver toxicity, so it might not be safe in our patients with PTSD who tend to have a common or a high risk of comorbid substance abuse. As far as other medications, prazosin may have some beneficial effects as adjunctive therapy, and they looked at other SSRIs and SNRIs, and they actually found that a few of them performed worse than placebo, specifically paroxetine and fluoxetine. They did also conclude that anti-epileptics, antipsychotics, and benzodiazepines were not effective and should not be used for the treatment of PTSD. In the late 90s and early 2000s, several scientists began studying the role of glutamate in the pathophysiology of PTSD. It was believed that this increased glutamatergic activity can cause alterations in the brain, and that stress can stimulate an increase in glutamate release. This release caused by stress is also similar to release of glutamate seen with NMDA antagonism. So Chambers in 1999 first speculated that perhaps ketamine could have neurotoxic effects by increasing glutamate release in certain areas of the brain, thereby causing alterations in brain circuitry. In 2000, Anand and colleagues looked at lamotrigine, which inhibits glutamate release, and found that this action actually decreased some of the ketamine-induced behavioral effects. So he concluded that these neuropsych effects of ketamine were probably related to excessive glutamate transmission, just by the fact that lamotrigine could help decrease these symptoms. In 2008, Schonenberg and colleagues performed a study to examine the effects of ketamine on some of the dissociative symptoms of PTSD after trauma. This was non-randomized, so we're not sure necessarily why patients received one therapy or the other, but they compared patients receiving ketamine, patients receiving opioids, and patients receiving non-opioid analgesics after experiencing an accidental trauma in their ED. And they used this ASDS score, which is a 19-item self-report score with 4 subscales related to the PTSD symptoms. They also completed another questionnaire. What they found was that patients who were treated with ketamine had significantly higher scores than those treated with either opioids or non-opioids for both the PDEQ and the ASDS and each of the subscales of that. What this means is that the patients treated with ketamine had significantly more severe symptoms of PTSD and had more severe dissociative symptoms. So the authors concluded that ketamine might modulate or worsen these symptoms of early PTSD, and perhaps ketamine has an additive effect with the stress, which could increase the risk of developing PTSD. However, as I mentioned before, this was limited by treatment selection bias. So again, we're not sure why some patients were treated with ketamine and others were given opioids. It was a retrospective trial, so there's a lot of cofactors that perhaps weren't evaluated, and it was a small sample size, so it's hard to generate any strong conclusions from this. At about the same time, McGhee and colleagues did a similar study looking at burn patients in the military. They realized that perhaps ketamine could be a risk factor for developing PTSD, and since it's used in such a large portion of their burn patients, they wanted to see if they were increasing the risk of developing PTSD by using this during their treatment. So they evaluated patients using the PTSD Checklist Military, which is a 17-question report that evaluates 3 clusters of symptoms, with more severe symptoms being rated as a higher score. And they enrolled 603 U.S. burn victims. The majority of these patients did receive ketamine. It's important to highlight some of the baseline characteristics of these patients. We'll notice that the patients in the ketamine group had significantly higher TBSA, total body surface area, so they had more extensive burns. They had a higher injury severity score, which means it's a scale from 1 to 75, with a higher number being more severe. So these patients were more critically ill, had more extensive burns, spent more days in the ICU, and received higher amounts of opioids while throughout their treatment. And what they found was actually patients who received ketamine surprisingly had a lower incidence of PTSD. That's not what they were expecting to find. They looked at other factors and found no correlation between PTSD symptoms and any of the other variables that they had collected. So the authors concluded that ketamine doesn't increase the prevalence of PTSD. It might actually decrease it. So this is completely contradictory to the previous study we looked at. However, again, this is limited by differences in baseline characteristics and a limited patient population. This was just done in U.S. military personnel, so perhaps we can't generalize this to the entire population. So several years later, Fetter and colleagues again set out to test the efficacy and safety of a single dose of ketamine, but now for the treatment of PTSD. So they did this in patients who were known to have a chronic history of PTSD, and they performed a randomized double-blind study to see if a single dose of ketamine compared to a single dose of midazolam would be effective for the treatment of symptoms. They enrolled 41 patients with PTSD, and their primary endpoint was the impact of event scale, revised scale, at 24 hours. And this report has subscales for intrusion, avoidance, and hyperarousal, the 3 symptom clusters of PTSD. What you'll notice here is on the top you'll see ketamine is the bottom line and midazolam is the top line. So for the IESR scale, a higher score means more severe symptoms. So you'll notice that immediately at day 1, although both ketamine and midazolam did decrease their symptoms, ketamine had a significantly greater reduction in symptoms. And this was sustained throughout the 7 days that they monitored the patients. On the bottom, you'll see essentially the same information, but they break it down into each subscale. And again, ketamine was had significantly greater benefits compared to midazolam for each of our symptom clusters. The authors concluded that ketamine was associated with a rapid reduction in PTSD symptoms as well as comorbid depressive symptoms. One of their secondary endpoints was a separate scale that looked at depressive symptoms. They concluded that ketamine is safe and generally well tolerated in patients with chronic PTSD. However, a major limitation of this study is that they were comparing it to midazolam, a benzodiazepine. Now, if we think back to our guidelines and the meta-analysis that we talked about, they all specifically say that benzodiazepines are not effective and should not be used for the treatment of PTSD. So I find it interesting that they chose to compare it to a medication that we know is not going to be effective and that is not recommended. Also, this doesn't address patients with new PTSD or at risk of developing PTSD. So we're not sure how ketamine from this study would be effective for a patient that comes in with a new trauma and we're worried about them developing symptoms of PTSD. So sort of to conclude the use of ketamine in PTSD, we know that glutamate plays a major role in the pathophysiology and that glutamate transmission is impacted by activity at our NMDA receptors. There's mixed data regarding the safety of using ketamine in PTSD patients. There is some literature suggesting that perhaps ketamine is effective at the treatment of patients who have known chronic PTSD, although we don't really know what dose to use. Several of the studies that we talked about didn't provide dosing information. Some of them just used a single dose, but we're not sure would it be effective perhaps for preventing PTSD, putting patients on a maintenance outpatient dose. Many of these haven't really been studied, so really we need some more literature to guide us on our appropriate dosing. One thing we know for sure is that we need to be careful in patients who have comorbid psychiatric conditions, because we do know there is good data to show that it can cause some psychiatric side effects and perhaps worsen some of these psychiatric disorders such as schizophrenia. So question number 3, which neurotransmitter is implicated in the interaction of ketamine with symptoms of PTSD? Okay, good, glutamate. So moving on, we looked at PTSD. Now we're going to look at the use of ketamine in refractory status epilepticus. So first, what is status epilepticus? Well, the old definition was that it's a seizure that lasts at least 30 minutes or multiple seizures over a 30-minute period that don't completely resolve. However, that definition has changed. The time limit now is seizures greater than or equal to 5 minutes. The reason for that is they found that seizures, once they persist beyond 5 minutes, the chance of it spontaneously stopping is minimal, and it's important for us to treat sooner rather than waiting until 30 minutes out to see if it'll stop on its own, because we've found that over time the seizures become more refractory to treatment. So if we wait until 30 minutes, it's going to be harder to abort that seizure than if we treat at 5 minutes. It's also been shown that seizures are perhaps caused by reduced GABA-mediated inhibition of neuronal activity. So here we have a picture of our GABA receptors and our NMDA receptors. So our GABA receptors are inhibitory, so anything that acts on these receptors is going to reduce brain cell firing, whereas our NMDA receptors are going to increase activity. Refractory status epilepticus is defined as a failed response to a benzodiazepine as well as another anti-epileptic drug. As I mentioned before, prolonged seizures may be more difficult to treat. One reason for that is that it's been shown that our GABA receptors, as a seizure persists for an extended amount of time, GABA receptors can internalize into the cell. So our agents such as benzodiazepines, which we commonly use to treat seizures, become less effective because there are less GABA receptors on the cell membrane for them to act on. At the same time, however, NMDA receptors are upregulated. So activation by glutamate is going to cause increased cell firing as more NMDA receptors become available on the cell surface. Here's a picture, just an image of kind of what I mentioned with the GABA receptors becoming internalized. As the status epilepticus persists, they can, through the process of endocytosis, they go from the cell surface into these vesicles. They can become recycled and go back to the cell surface, but they can also be degraded in lysosomes. So we do have guidelines to direct our therapy. The Neurocritical Care Society has produced guidelines for status epilepticus, and you'll notice that our first-line treatments for emergent treatment are mostly benzodiazepines. This largely comes from a VA study that found lorazepam to be significantly more effective, or the most effective out of 4 different treatment options, comparing lorazepam, phenytoin, diazepam plus phenytoin, and phenobarbital. There's really not a lot of great data to guide us beyond benzodiazepines, though. After emergent treatment, they provide guidelines for urgent treatment, so what drug to give second after we have controlled their initial seizure, but we want to maintain that seizure control. And then also for refractory treatment, so what if our first-line therapy fails? Similarly, the American Epilepsy Society has produced guidelines. First line, this may be kind of hard to read, but benzodiazepines are the initial therapy of choice. But beyond that, our second line and third line, they don't give strong recommendations. They just say there's really no evidence-based preferred second therapy. And it's a level U recommendation. Essentially, it's expert opinion that maybe some of these others, the fosphenytoin, the valproic acid, the levetiracetam, might be effective, but there's not a lot of evidence to support their use, anything beyond benzodiazepines. So recently, ketamine has started to be studied. In 1990, it was first studied in animal models. They induced seizures in rats and tested ketamine. Subsequently, they did studies in piglets. In 1996, we have the first report of using ketamine in a human. It was actually a case series of 26 patients in a neuro ICU. Only one of these patients actually received ketamine, but it was kind of the last line therapy after they had failed everything else that they could throw at them. They were on general anesthetics and still having seizures. They put them on a ketamine infusion at 100 milligrams per hour and did successfully achieve seizure control. A few years later, a case report was published about a 13-year-old girl who had seizures refractory to pentobarbital. They gave her a ketamine bolus, started an infusion for 14 days, and again, they were successfully able to achieve seizure control. Since then, there have been a number of case reports and small case series of the use of ketamine in refractory status epilepticus. There's a lot of information on this slide, but really what I want to highlight is most of these are very small, either a sample size of 1 or very few patients. The dosing is not standardized, so some have used just a bolus, some use a bolus and infusion, some might just use an infusion. And in general, they've had good outcomes, although there's likely some reporting bias here. I'm sure there may have been other cases where it's been tried and didn't work, and so they didn't bother to write it up and try to publish it. Similarly, there's been a number of studies in pediatrics as well as adults that have all had similar outcomes and a wide range of dosing regimens used. I do want to highlight a few of the reports out there. There was a study by Kramer that actually looked at ketamine early in status epilepticus. So most of the other reports were kind of last-line therapies after they had tried multiple other options. But Kramer reported successfully using ketamine fairly early in status epilepticus. It was started within hours of onset. They gave a 50 milligram bolus and then a 40 milligram per hour infusion. They gradually increased the rate up to a maximum of 220 milligrams per hour. and they did successfully achieve seizure control with this. In their discussion section, the authors described their theories for why they think ketamine worked in their situation early in the course of the status epilepticus. They reasoned that this upregulation of NMDA receptors occurs over a period of hours rather than days to weeks. So rather than waiting days out to start ketamine, it might be more effective to start it early before there's any long-term permanent brain damage caused by the seizure. They also reasoned that a lot of studies have given a bolus and maybe they achieve initial control of the seizure, but that isn't maintained if you don't give the infusion following the bolus. So they found that giving a bolus and then maintaining seizure freedom with an infusion led to good outcomes in their patient. Also, they found that in their case, their patient had been on midazolam and propofol, and they were having to titrate the drips up pretty fast. They actually had to start their patient on norepinephrine because the patient was becoming hypotensive. Once they started the ketamine, this minimized the need for this norepinephrine. So perhaps combining drugs could minimize the adverse effects associated with any one single drug. This is just a diagram of, as I mentioned, where they were titrating up this norepinephrine drip. You'll see that once they started the midazolam and propofol, they were having to increase the rate of their norepinephrine up until they started ketamine, and then it leveled off, and actually they were able to decrease a little bit the rate of their norepinephrine infusion. Gaspard and colleagues published a large study of a multi-centered study representing 60 cases of refractory status epilepticus, and the purpose of this study was really just to report the use of ketamine and see how it's been used and is it being effective for the treatment of status epilepticus. So they looked to see if patients achieved control of their seizures and then if this response was likely or probably due to ketamine based on the timing of when they received the ketamine and if ketamine was the last drug they received prior to seizure control. So what they found was that ketamine was started a median of 9 days after the onset of status epilepticus. So again, we're not really seeing that early use of ketamine here. It's being used much later in therapy. Patients received anywhere from 2 to 12 concurrent anti-epileptic drugs. There was a wide variety of dosing regimens with boluses and infusions, and a wide variety of durations for how long patients were on the ketamine. They found that 57% of patients in this study achieved control of their status epilepticus, and about a third of these were either possibly or likely due to the ketamine. Importantly, they found that no patient achieved a likely response to ketamine if their infusion rate was less than 0.9 milligrams per kilogram per hour, suggesting that perhaps this dose isn't high enough. And also, no patients received a likely response if ketamine was started at least 8 days after the onset of their seizures or after the failure of 7 or more medications, suggesting that maybe we need to use ketamine earlier in our treatment. Ketamine did have to be discontinued in 4 patients for cardiovascular side effects. This table just shows some determinants of ketamine efficacy. You'll see on the left, patients with a likely response started ketamine after a median of 12 hours after seizure onset and after failing only 4 medications, whereas in the right column, patients with no response to ketamine didn't start ketamine until 10 days out and after failing 8 medications. Again, suggesting that maybe we're not using ketamine early enough in our algorithm. And then Sabharwal just last year reported a retrospective analysis of patients with super refractory status epilepticus, which they defined as status epilepticus failing therapy with benzodiazepine, other anti-epileptic drugs, and 24 hours on general anesthetic. So they reported the use of ketamine and propofol combined. And there was, again, a wide variety of doses and durations. But they found that they had a very good response. 91% of patients in this study had seizure control, and they had less than 40% mortality, which is similar or lower than what had previously been reported in the literature. One thing to note in this study is that patients were started on ketamine typically between 24 and 48 hours from seizure onset, the majority of the patients. So again, they were advocating for early use of ketamine. They concluded that ketamine infusion with or without propofol seems to be effective in controlling this super-refractory status epilepticus, and that ketamine has a favorable hemodynamic profile. They didn't really see many side effects with the ketamine in this study. However, this was limited because it didn't have a control group, so they weren't comparing it to anything. Also, the patients received ketamine and propofol, so we're not sure if it was the ketamine that was beneficial or if it was just the propofol that was helping them achieve freedom from seizures. And again, there's a wide range of doses, so it doesn't really provide us much guidance on what dose to use. This is just sort of a summary of the range of doses and responses we've seen in the case reports and case series to date. So question number 4, what is one theoretical reason why ketamine may be more effective than benzodiazepines when we have prolonged seizure activity? Good. So our GABA receptors are downregulated and our NMDA receptors are upregulated. So our benzodiazepines, which are going to act on those GABA receptors, are going to be less effective because there's going to be less GABA receptors for them to act on. So here at UVA, what are we doing with ketamine? We do have an order set in the NNICU for status epilepticus. It comes as a loading dose and then a maintenance infusion. So our 1 milligram per kilogram loading dose is administered over 3 minutes. And then our infusion, the prescriber can choose 1, 2, or 3 milligrams per kilogram per hour to start the infusion. We can titrate this up. Our smart pumps have a soft max limit of 5 milligrams per kilogram per hour, but again, it's a soft max, so we can exceed that if we need to. I ran a report over the past 24 months to see how often we're using this. Only 4 patients have actually received these ketamine infusions for status epilepticus over 2 years, and 3 of the 4 patients achieved successful resolution of their seizure activity. Here's just an image of the order set. So again, you can see that with the infusion you have options of what dose you want to start at. And here's again the order as I'm verifying an order for a patient who received the ketamine infusion. So just to summarize the use of ketamine in status epilepticus, we know that prolonged seizures can lead to the downregulation of GABA receptors. So many of our drugs that we use for the treatment of status epilepticus, including benzodiazepines, become less effective as our seizures persist. At the same time, though, our NMDA receptors are upregulated, so perhaps ketamine has an important role in these prolonged seizures. There's growing evidence now to support the use of ketamine in the treatment of refractory status epilepticus. And at UVA, we have used ketamine, but not very often, and it's always been last line. Perhaps we need to start using it earlier in therapy. So we're almost there. Just some takeaway points from today. Ketamine, it's indicated for anesthesia and procedural sedation, but it's been reported in many other off-label uses, as we've talked about today. It may be safe to use in patients with a history of PTSD or those patients at risk of developing PTSD. Although there's kind of conflicting data in PTSD. And ketamine, finally, it's been demonstrated that it has good efficacy in refractory status epilepticus. Perhaps we should be using it earlier in our treatment algorithm because we've seen good results with it. We just haven't been using it very frequently. And I think a large barrier to this is just prescribers and pharmacists were just not as familiar with it as with most of our go-to drugs. So hopefully in the future maybe we'll see it used more often. So what questions do you have?
Was it enough? I mean, you said when they used it at UVA, that order set is on the lower side. Is it enough? I mean,
Actually, I don't remember now how. I didn't look to see what doses we actually titrated up to. So that's just the initial infusion rate, and they titrate up to response. But
Are they all adult patients? Or?
All the ones that we've used it here that I've seen, yes.
Where would you put ketamine in the existing guidelines based on what you've seen in the literature and your experience here?
I would still use benzodiazepines first line just because that's they're more well studied. And there was actually, I didn't include it in here, and it's been 3 months since I looked at the article, but there was another article that I had read that their institution had actually made institutional guidelines, and it was based on previous response or previous treatment. So their first time you were treated for status epilepticus, you received a benzodiazepine, and then if you had, if that failed therapy, then you were given ketamine was second line. If you had previously been treated with a benzodiazepine, if you had a successful response, then you were given a benzodiazepine again. If you failed therapy, then you were immediately started on ketamine first instead of trying a benzodiazepine again. And they were somehow into their algorithm, they worked the time that you were, time from seizure onset. So I don't remember the specifics if it was 48 hours, but if you presented beyond that time limit, instead of starting with a benzodiazepine, you jumped straight to ketamine.
How did other traditional therapies like propofol, other anti-epileptics,
They were,
play into that?
I think, after ketamine. Then if you failed ketamine, you turned to them.
Okay.
But that was in pediatric patients. Well, that's unfortunately with ketamine. So many of these reports are sort of those patients where, well, we've tried everything else.
And it's so late in the therapy that it's not even going to work.
Right.
As well.
Right. Because that's what I know. Like the hospital that I mentioned in this other study where they were trying to use it earlier in their algorithm instead of saying, well, we're going to try benzodiazepine and then we're going to try propofol and then we're going to try all these other anti-epileptics that have been around, and then 2 weeks out, well, we've got nothing out left, let's try ketamine. They're saying, well, let's start it up front. Let's do it, first or second line.
Can you do it like that without an approved use? Yeah. You should.
I think as more reports and more studies come out, once we have more evidence to support it, I think people will come around. It's hard to be the first institution to make that big jump.
Are there certain types of patients that you would not recommend ketamine use for status?
Just in general with using ketamine in patients with they say to be careful if they have a cardiovascular history because it can, that increased demand on the heart can cause problems. But I think if you have a patient in status epilepticus, that's a big enough issue that I'm not going to worry about exacerbating their schizophrenia symptoms if I'm going to be doing something to achieve seizure freedom. And there's, just because we don't have a lot of evidence to say that there's not enough patients to do subgroup analyses to say that this set of patients it was effective and this wasn't, or this, maybe the risks outweigh the benefits. So I don't think there's any, at this point, I don't think there's any set of patients that I would not use it in.
Did any of the authors comment on how they removed agents, especially for those that I was successful in? The one larger study looked at where you potentially had patients on 12 different agents at the same time, and so of course the problem is then, okay, great, we finally stopped your seizures, which one do we stop first? So ketamine is the last agent to go on. Was it also the first agent to come off?
Most of them did not specifically say how they titrated off. I do remember there was, and I don't remember specifically which one, there was one where they were on with, they were on ketamine and propofol and midazolam, I believe, and they talked about, I think the ketamine was the first one that came off. Or maybe, I think they weaned off the ketamine and the propofol simultaneously, and then the midazolam they kept on longer.
Are you still writing?
All right. Well, thank you guys for coming.